So I am delighted to welcome our first speaker, who is Rebecca Cotton, Acting Deputy Director, the Mental Health Network. Becky.
Thanks, Rowan, and thanks for the introduction, and thanks for inviting me to come here today. There is nowhere to put my water. There we go. Okay, so I'm just going to take the next 10 minutes or so to sort of set the sort of big picture for this conversation, talk about long-term conditions and the links with mental ill health, about the health inequalities experienced by this particular group of people, and some of the challenges for providers in providing the right sorts of services for this group. Just to kick off, I thought I would explain a little bit more about the Mental Health Network and some of our work in this area. Some of you will be familiar with us, some of you might have never heard of us. So for those of you who haven't, the network is part of the NHS Confederation. We're a membership organisation. 90% of NHS trusts and foundation trusts providing mental health services in England are in membership, as well as a substantial number of the larger independent sector and voluntary sector providers as well. In terms of our work, like most other membership organisations, we have a strong programme of activity around policy and influencing legislation. We also do a fair amount around spreading good practice through our publications and our events, as well as running development programmes aimed at supporting service improvement. In terms of the mental health of people with long-term conditions, we've done quite a bit of work in this area, particularly over the last year. We were supported by the SHA Mental Health Leads Group and the Department of Health with some funding to do 2 reports last year. Both of those are available on our website, by the way, if anyone wants to have a little look. These looked at the evidence around investing in psychological support for people with long-term physical conditions. And they showcase some interesting examples of integrated care for this group of patients, including some great examples of acute trusts and mental health trusts working together to jointly provide some services. I thought that some of these statistics would set a bit of context. None of these, hopefully, are going to be anything new to anyone sitting in this room, I'm sure, but they're probably worth kind of bear repeating. 15.4 million people in England have a long-term condition, have one or more long-term conditions. And we also know that 30% of those people will have a mental health problem in some way, shape or form, usually a common mental health problem such as anxiety or depression. People with one long-term condition are 2 to 3 times more likely to develop depression than the rest of the population. And that's probably not particularly surprising. Living with many of those sorts of conditions can inevitably bring with it lots of stress and strain for individuals and for their families too. So given we know there's a strong link between having a long-term physical condition and experiencing poorer mental health, what are the implications of that for the NHS? Well, broadly speaking, firstly, those people commonly experience poorer outcomes from their care and treatment, and that goes in terms of their mental health outcomes, but also their physical health outcomes as well. And I'll talk a bit more about that later on. Secondly, and crucially for us thinking where we are in terms of the NHS funding situation at the moment, there's this issue of increased costs. The King's Fund published this great report a couple of years ago that looked at the economic costs of long-term conditions. And as part of their modelling, they made an attempt to try and cost how much NHS spending on people with long-term conditions might be associated with poorer mental health. And they reckoned that around £1 in every 8 spent on people with long-term conditions is down to poorer mental health. And that's probably between £8 and £3 billion of NHS spending associated with that. So that's about 10% of the total budget for the NHS. That might sound like a hell of a lot of money, and it is. It's very stark, but it's probably not that surprising when we think about the costs of how poorer mental health might lead to them using healthcare resources more frequently, increased presentations in primary care, more presentations at the ED, increased use of medication, certainly higher sort of admission rates and longer lengths of stay. So it's probably not that surprising that the costs are that high. And that's obviously before we think about the wider costs outside the NHS. And we know that particularly for a lot of people with long-term conditions, staying in work can be very difficult. And if we can do sort of things to help people stay in work and be economically active, there's obviously those sorts of costs to think about as well. What I thought I would do, given the short amount of time that we've got today, I thought I'd just look at two particular examples of long-term conditions and their links with mental health. I thought I'd talk about diabetes first, and then I'd talk about COPD. Looking at diabetes care, depression and anxiety is particularly common amongst this group of patients. 41% of people with diabetes report having poor psychological well-being, and data from the US indicates that around 13% of all new cases of type 2 diabetes will also have a clinical case of depression alongside it. We also know that for people with diabetes, people who are depressed may not manage their condition very well, and they commonly have to take more time off work as a result. If they're feeling depressed, they might be affecting their food choices and whether they take their medication correctly. And obviously, poorly managed diabetes has got some very serious consequences and leading to amputations and all sorts of other complications. But we also know that psychological interventions have been shown to improve the way people can actually manage their own condition and actually lower their blood glucose levels. The evidence also shows us there's considerable scope for savings here to the NHS by redesigning care pathways to include psychological support. The DH commissioned the LSE and others to conduct an economic analysis of the collaborative care model for patients with type 2 diabetes and comorbid depression. And they found, whilst there was considerable upfront cost in doing that, in year one, after 2 years it became cost effective. And in terms of how sort of providers have been responding to this, what we found in our research last year was that a very wide variety of approaches were being taken. In some areas, they were certainly way ahead of the curve in thinking about whole person care in this way. We've seen acute hospitals directly employing their own psychologists and mental health professionals as part of their core team delivering diabetes services. That was certainly the case with King's College and also at Bournemouth. In others, like in West London, we saw the mental health provider and the local acute provider coming together to deliver an integrated service jointly. I said I'd also have a little look at COPD. Amongst this group of patients, we know there's a much higher rate of common mental health disorders than amongst the general population. It's not hard to understand why that might be. Experiencing breathlessness can be very distressing and difficult to control, which in itself can create a vicious cycle. And that sense of panic in turn can result in someone becoming even more breathless and turning up at the ED and so on. By addressing that comorbid depression and anxiety, we can improve people's ability to manage their illness and feel more calm and in control of their situation. And that hopefully results in people spending less time in hospital and improving their overall quality of life. Providing that psychological support that is something that's supported in the literature as being beneficial to patients. The NICE guidance in this area recommends a range of interventions, including the use of CBT, cognitive behavioural therapy, delivered by respiratory nurses themselves. So they go through CBT training to deliver that. These sorts of approaches are relatively low cost and have delivered improvements in helping people control their anxiety. And in terms of the sort of, as with the diabetes examples actually, there's considerable scope for the NHS to make savings and improve quality of life. In the report we published last year, we cited an economic evaluation of the breathlessness clinic in Hillingdon, and they calculated that if the model they were using there were rolled out nationally, that over 10 years you could save nearly £500 million. There's a very different approach being taken in Sutton and Merton. Their IAP service piloted a group programme for local people with COPD, and they found, as you might expect, the outcomes for people who went through that programme were improved and people were actually using healthcare resources less. When they looked at the subgroup of patients who went through that programme who were particularly high users of local healthcare services, they reckoned if they targeted more interventions at that group, they probably saved around $300,000 to the local health economy in 1 year. So all of that begs a very obvious question. If it saves money and it benefits patients, why aren't we joining this care up better? We know that people with long-term conditions often experience poor mental health, and we know that their quality of life is poorer as a result of that. We know that their physical health outcomes are likely to be worse, and we know that we can save money by providing psychological support to this group of patients. So what are some of the barriers we need to overcome in terms of getting there? And I know Caroline's going to talk quite a bit more about this when she gets up to speak. But just from a sort of provider perspective, I think there are a number of challenges to overcome. The traditional silos in provision and commissioning definitely don't help. I don't know if anyone's been paying attention to what Andy Burnham's been saying recently from Labour. I think he spoke here yesterday, potentially. Okay. His main preoccupation is about we've got 3 separate systems for physical health, mental health and social care, and that works against us providing truly integrated care. I think we're going to need to work a lot harder at kind of working across organisational structures. I'll skip through these, but payment mechanisms and incentives, I think Caroline's going to talk about that too. There's a question here about a lack of awareness amongst, is there a lack of awareness, mental health awareness, people who are planning and delivering services? Is stigma being... Also, you see that often you see coordinated care being delivered by people despite the system and organisational silos, and we need to make it easier for them to deliver better care. And just lastly, I will wrap up now, I'll skip that. But I wanted to say a quick word about the physical health of people with mental illness. People with schizophrenia die 15 years earlier than the population average. They're twice as likely to die from coronary heart disease as the general population. There's a huge challenge here around health behaviours, smoking, obesity, drug and alcohol. I don't have time to go into that, but I thought I would be a bit remiss not to highlight that that's the flip side of this coin. And if people involved in this room in commissioning, when they go back to their areas, could have a look at how they're tackling the physical health of people with mental illness, that would be great. Thanks very much.
Okay, thank you very much indeed. I'd now like to introduce Caroline Dollery, who is a member of the Mental Health Commissioners Steering Group for the NHS Clinical Commissioners. Caroline.
Yes, thank you for coming. I'm actually a practising GP. I work 2 days as a GP in Chelmsford near Essex. I'm also on the steering group for the NHS Clinical Commissioning Network and also Clinical Director for the East of England Strategic Clinical Network. So I have multiple hats. There's a lot to talk about, and I'm going to be brief because I'd really like to get questions from the floor about practical experiences. Really, we've done the evidence, we know about that, but I'm going to take a very practical approach here about what's actually happening out here in commissioning land. I sit on my CCG board, so I'm privileged to actually have a view from that part of the world and also from the kind of bigger strategic area. Rebecca mentioned all of these things. We know there's a huge amount of money tied up in this, but we also know mental health is the lowest funded, so parity is not there. And actually the biggest challenge as a commissioner is the fact that if you want to get mental health integrated into physical pathways, where does the funding come from? We know also that these people tend to be from more deprived areas, the patients, the families and the carers. So access is a big issue. People don't come and see us as GPs. Employment is important, social care and well-being is important. Some of the really exciting work around the country has been places like Sandwell. They've taken a very holistic approach to caring for people with these sorts of conditions and don't just think about the health, they also think about their environment that they're working in. So a plea for reaching out to hard-to-reach groups. We know outcomes are better with integrated approaches, and we know case management is critical, that we need social care community matrons, we need mental health workers, GPs, nurses working together. Collaborative care we know works well, and the innovative liaison psychiatry within urgent care is something that's been used widely. In the East of England, we came from a very low point to having the lowest number of psychologists per head of population nationally. So when I started this work about 8 years ago, it was quite a challenge, actually. And primary care had nothing, really. You know, waiting list for counsellors, maybe, for about 6 months if you were lucky. And 2-year waits for psychological therapies for seriously mentally ill patients in parts of the region. In fact, to be honest, around me, it's still 2 years. Where are we now? We've got IAPT, and that's helping, but it only helps around 15% of the population. It doesn't help everybody else. It's not the only solution here. We do have centres of excellence. We've got really exciting, innovative projects around the country, which I'll allude to. We're beginning to get a lot of shared learning going on, and that's where networks become really, really important. We have GPs at a local level around me. We have in North Essex, 3 CCGs have a network that we work together with providers and with the local authority. We have regional ones through the strategic clinical networks developing. Actually, for us, we already have a managed clinical network, the first one in the country, which has been running for a year. And we've got lots of ongoing work with local authorities about how we do genuinely try and integrate our approaches. And that's a massive challenge because they're very different cultures in the way we work. Looking at strategically, in the east of England, we've looked at the SDN at all of the plans on a page, and everybody's got mental health there, which is great in the east of England, including dementia and physical and mental health, all that good stuff. But not all CCGs nationally by any means have, and not all of them have a clinical mental health lead, which is really concerning. But most do, so that's the positive. We must, remember that. So we've got pockets of good practice. The National IAPT Long-Term Conditions Project is being evaluated by Andre Tiley, and I'm sure that will be launched and be very interesting to see the findings of that. And I guess the challenge is, for us as commissioners, we've got to stop the stuff that doesn't work, and we've actually got to keep doing the work that does work. And that takes a degree of courage to actually stop and decommission work that isn't working effectively. Examples of pilots and services that are up and running already. Huge range. I'll talk a little bit about Mid-Essex, where I'm from. We're just about to embark on a Frailty Project, which is around comorbidity. So risk stratifying our patients in general practice and then delivering multidisciplinary approaches with mental health workers to actually support people who are most at risk of admission, most at risk of actually getting seriously unwell. There's lots of holistic work in other parts of the country looking around MUS, stroke. Pain is a big interest, rapid access chest pain, older people is a target. Around us we've got a lot of interesting work on veterans actually. So as you can see, there's quite a lot going on. One of the barriers, of course, is all of this stuff. Whoever said there'd be less bureaucracy when we organised, the last year has been really difficult for everybody in transition. I think we're just beginning to get our heads above the parapets. And I think we've now got some really, really strong links with the local authorities through health and wellbeing boards. And I think that's going to be a massive help in getting some of this work going. Barriers, information. Geraldine Strathedy is the National Director for Mental Health, and she's on a mission to actually make sure we have good mental health and social care information. And I'm keen to get feedback from delegates on how we can actually find out what would help, what do we need in the national minimum data set that actually helps us contract for better mental health and physical health. Funding flows are tricky. There's the NHS England, there's local authorities, there's our CCG flows. It's not that straightforward. And skills and knowledge, it's patchy. Some people are really good at this, some people are in the middle, some people are uncertain. And so training and education of commissioners and providers, and that includes the local authority, is going to be critical to make this work. There's a lack of holistic approach with pathway redesign. Even on my place, I keep saying, don't forget to add mental health when you're looking at these pathways. You have to keep nagging people to do this. And there's a real challenge at the front line of getting people to understand what this is about. And I think there's a need to support frontline staff in understanding why this is important. And the stigma is interesting. We had a really good example with COPD. We had a chap who came into our CPD IAPT service, and for about 4 or 5 sessions he refused to engage at all. Eventually it came out, he explained to the group he was having massive numbers of panic attacks. And it took him probably 6 sessions to own up. And the consequence of that is that he actually improved enormously after that and actually got a lot of group debate about how you can help with anxiety and COPD. So the stigma is the thing not to forget about. People need a lot of support to get there to the point they can actually admit that they've got problems. Information is a problem. Lots of places it comes from. There's battles going on nationally about social care and what people can see and what they can't see. As I say, Geraldine's on a mission to try and help us improve this. The fact that social care and healthcare systems don't work together, and lack of outcome-based data. And that's something we need to focus on here, is making sure as commissioners we start designing proper outcomes. PBR, acute care. Then you've got cluster care for shadow PBR for mental health, completely different systems. So we've got to try and make that match. And actually, we've got to understand we're facing huge financial challenges, and it's going to take a lot of evidence for us to actually keep persuading our boards as CCGs that this is worth investing in, that we can actually achieve financial savings and improve quality. This is the key, isn't it? We're improving quality at the same time. So, with skills and knowledge, how do we spread the capability? How do we change the culture from service-based pathway approaches to linking it to outcomes? How to demonstrate cost effectiveness and how to engage in prevention and self-management, because this is key. If we're going to survive in a financial challenged world, we've got to get people self-managing better. And how do we shift the care out into the community, not have everything in secondary care? So the direction of travel, clinical targets, these are things that I know people are targeting at the moment actively. Interesting resilience and coping strategies and self-esteem is really important, and this is a very cost-effective intervention. You can look at the Sandwell data to show that. If you actually get people to do group work, individual work, to build their self-esteem, they will actually often be able to cope with their physical health much, much better, and it's quite cheap to do. Patients and families and carers, you must remember the families and carers in doing this as well, especially with an ageing population. I've mentioned health and wellbeing boards is really critical. We are now just getting to the point locally where we've actually got multidisciplinary teams, social workers attached to practices, so we can actually directly start working with frontline staff in terms of improving outcomes. But there's also the bigger picture stuff about 10 years' time, which Rebecca alluded to. A lot of this stuff is going to take time to deliver, and in the financially challenged world, the pressure can sometimes be you've got to do it now. Public engagement is interesting. You take this out to the public, they really like it. They like the holistic approach, they like the attitude. And I think if we can, through the Health and Wellbeing Board, start getting the public on board to actually start designing some of these approaches, it might help us a great deal. Urgent care usage is a great lever. We know lots of people go in and out of A&E constantly with these conditions, and it's hugely costly, and they don't get good quality care. So a hook definitely to get commissioners on board with this is to focus on your A&E data, which is where we started from in Mid-Essex in terms of getting our COPD pilot up and running, our frailties coming now. Reablement, getting people to be self-sustained. Looking at risk stratification tools, that's something, there's a lot of interest in how we can use risk stratification tools to target populations. There's a community budgets pilot looking at joint health and social care working. And through the network, we're hoping to set up a training and development of commissioners. And we've got a meeting at 1 o'clock today to launch the NHS Clinical Commissioners Network. That will include providers and it will include local authority, but it's driven by GP commissioning. I've mentioned all of that. I'm whizzing through this because we've only got 5 minutes. I think I'll finish there because I've spoken to all of that. Now I think we'll leave the floor open for questions.
Okay, well, thank you very much indeed. Rebecca, would you like to join Caroline at the lectern? And what I'd like to do first of all is, like Rebecca and Caroline, perhaps you could each say what would be the thing that would most help working together to move forward with some of the challenges you've talked about. If you had one wish, each of you.
That's a good one. One wish. Gosh.
I think that, I mean, it's a big wish, but I think sorting out the payment mechanisms and incentives is a huge one.
So sort out the payment, and Carolyn?
I think it's actually getting providers and commissioners around the table and thrashing out the information and the payment properly, so that we can actually test things out and take risks, because the thing you need to do is take a risk, because it won't always work. We learned that with our COPD. We've actually changed our approach completely. So changing to a kind of risk culture, you know.
Okay, so sort out the funding, talk to each other and be brave. Now, any questions from the floor? There's a microphone coming.
You had mentioned respiratory nurses with CBT training. How many are there available at the moment?
Sorry, can you repeat the question? We didn't quite hear you.
You mentioned respiratory nurses with CBT training.
Yeah.
How many are there at the moment in the UK?
In the UK?
And in London?
Right.
How available are they?
I'm a bit geeky when it comes to stats, but I'm not that good. I'd have to go away and find out for you. But it's just an interesting approach being taken.
In London, a lot of the innovative work around COPD has occurred. So it's Hillingdon, George's did some interesting work, and I believe that there should be pulmonary rehab teams in all areas, because that's nice guidance. There should be, and if there isn't in your area, it should happen, because that's nice guidance. The key to it is actually training the pulmonary nurses to be able to be mental health aware, and actually give them some CBT techniques to use. If you're very lucky, you can actually get a psychologist working with them as well for a while, because that's the most effective, but that's not always possible.
Thank you. The gentleman in the blue shirt behind you.
Thank you. Jonathan Buisson from Boots. Have you any experience of using pharmacy with any of these services?
Pharmacy is always part of my service redesign. You don't need to worry. I was chair of medicines management for years, so I'm brainwashed. No, medicines management is key. You know, you see reduction in oxygen usage, you see reduction in all sorts of medication if you actually improve people's mental health outlook. Absolutely.
Okay, thank you.
My name's Tricia Birchley. I chair the Buckinghamshire Health and Wellbeing Board and agree with an awful lot of what you say. And our line at the moment is to promote healthy lifestyles and to try and prevent an awful lot of the problems you're talking about. One thing I've noticed locally, because we have Prevention Matters in Buckinghamshire determined to help people to delay the day when they need our services, is the waiting times to see mental health consultants. Older people are waiting weeks to resolve a problem which could help everybody if they could just get that advice that they needed quicker. Is there any way we can make this happen? I don't know how these people work their timetables and their scheduling, but it seems to me it's a bit of a problem just at the moment, this lengthy wait to see a consultant for older people.
I couldn't agree with you. Waiting times in mental health services is a huge issue. Norman Lamb, I think, spoke here yesterday. We always knew that was his particular bee in his bonnet when he was in opposition, was about waiting times for mental health services, so we knew he wanted to do something as soon as he came in. There is something in the NHS mandate that puts a duty on NHS England to look at waiting times in mental health and come up with some kind of plan, and that might include access standards. At the moment, the NHS Constitution has the 18-week guarantee. It doesn't apply to mental health services, and I think that might be something a few political parties might want to look at in their manifestos, actually, and I wouldn't be surprised if they did.
I'd also add that the key to this is trying to shift away from a secondary care model. Get consultants involved where they need to be, but get them working with primary care, because access is much easier. And what you need to do is, I would really encourage you to talk to Dr. Ian Walton in Sandwell, because they've done some really good work on that. Cambridgeshire have done some really good work on liaison psychiatry as well. But they also want to try and kind of expand it out into the community more, because actually you can reduce waiting time significantly if you actually train up frontline staff in primary care to do some of this work. We know this with other conditions. You know, we've been doing it in gynecology and cardiology for years, so you can have a consultant-led GP with a special interest, for interest, or nurse practitioners. And you can actually do a lot of these interventions if you take a stepped care model. You can actually do a lot of these interventions not having to go and see a secondary care doctor. I'd also say psychology is critical here. It's not necessarily a psychiatrist people need to see, it's actually a psychologist, and we're really short of psychologists, and nationally we need to put some pressure on, because there's a drive to reduce psychology services, which is not good.
Okay, I'm very sorry, we're going to have to stop now. If those who want to ask questions could perhaps corner the speakers after this session.